Hello everyone, hope you all doing well. So the topic of today's discussion is pulmonary hypertension. So pulmonary hypertension is characterized by mean pulmonary arterial pressure of more than 25 mm of mercury at rest and more than 30 mm of mercury with exercise, or pulmonary wedge capillary pressure of less than or equal to 15 mm of mercury and pulmonary vascular resistance of more than or equal to 240 times. So these are the 5 groups of etiologies revised by WHO, and we will discuss them one by one. Group 1 is pulmonary arterial hypertension, 2 is left-sided heart disease, third group is lung disease and chronic hypoxemia, group 4 is chronic thromboembolic diseases, and group 5 is miscellaneous. So in pulmonary arterial hypertension, there is mutation in morphogenetic protein receptor 2, and a smooth muscle cell proliferation will occur, endothelial cell proliferation will occur, and there will be imbalance between vasoconstrictors and vasodilators. That is, the vasoconstrictors will increase and vasodilator will decrease. So the vasoconstrictors include thromboxane A2, serotonin, and endothelin 1. These all are vasoconstrictor, whereas prostacyclin, nitric oxide, and vasoactive peptide are vasodilators, and they will be decreased. So the types include idiopathic pulmonary arterial hypertension, familial pulmonary arterial hypertension, and pulmonary veno-occlusive diseases. Idiopathic one occurs in young people, 20 to 30 years of age, and mostly women. And the familial one is due to mutation in protein genes. So the associated conditions with pulmonary arterial hypertension are connective tissue disorder like mixed connective tissue disorder or CREST syndrome, which is a less severe form of scleroderma. Congenital left to right shunts, example ASD, VSD, PDA, and they will cause Eisenmenger syndrome. HIV infection, drugs and toxins, thyroid diseases, glycogen storage diseases, Gaucher's disease, and hemoglobinopathies. These all can cause pulmonary arterial hypertension. So the second group is left-sided heart disease, which will lead to pulmonary arterial hypertension. These are left atrial and left ventricular dysfunction, left-sided valvular heart disease like mitral stenosis and mitral regurgitation. They can lead to hypertension. Lung diseases and chronic hypoxemia like COPD, interstitial lung diseases, alveolar hypoventilation, chronic hypoxemia, sleep apnea, developmental abnormalities like severe kyphoscoliosis. These also can cause pulmonary hypertension. Chronic thromboembolic diseases like proximal and distal pulmonary embolisms, non-thrombotic emboli like tumor, foreign bodies, parasites, and sickle cell disease. Miscellaneous group includes sarcoidosis, histiocytes X syndrome, schistosomiasis, compression of pulmonary vessels with tumor, adenopathy, histoplasmosis, or radiotherapy. So the patient of pulmonary hypertension will present with shortness of breath and exertional syncope due to hypoxia and reduced cardiac output. Exertional chest pain can occur due to right ventricular ischemia. Symptoms of right heart failure will be there like tender hepatomegaly, peripheral edema, ascites, etc. Signs will include raised JVP with prominent A wave, parasternal heave due to right ventricular hypertrophy, prominent pulmonary component of second heart sound, right ventricular third heart sound can be heard. On ECG, there will be right axis deviation and right bundle branch block, right atrial enlargement, which is also known as P pulmonale, and right ventricular hypertrophy can also be observed by ECG changes. ABGs will show decreased partial pressure of oxygen and decreased saturation and partial pressure of carbon dioxide. Increased AA gradient will be there. Chest X-ray and high-resolution CT chest will show dilatation and pruning of pulmonary arteries. You can see in this image, right atrial and ventricular hypertrophy can be seen. Transthoracic echocardiography will show increased right ventricular systolic pressure, tricuspid regurgitation, or pulmonary regurgitation. So pulmonary hypertension is incurable, however supportive measures can help. For example, oxygen, we have to maintain oxygen saturation for more than 90% and it will reduce vasoconstriction. Diuretics can be given, they will decrease right ventricular stress and relieve right heart failure signs. Digoxin can control atrial fibrillation, anticoagulation with warfarin in case of thrombotic event. Vasodilators like calcium channel blocker, nifedipine and diltiazem can be used. These are used in the patient with positive acute vasoreactive response. What is vasoreactive response? That using inhaled nitric oxide, there is decreased pulmonary arterial pressure of more than or equal to 10 mm to a level less than 40 mm of mercury with stable cardiac output. It helps identify patients who will benefit from calcium channel blocker, and they are also associated with decreased mortality. IV prostacyclin can be used for vasodilation, and it will also decrease platelet aggregation and smooth muscle proliferation. The benefits increases with time and it decreases mortality rate. Endothelin receptor antagonists can also be used, but they have some side effects like deranged LFTs, headaches, anemia, edema. So they all should be checked. Phosphodiesterase 5 inhibitors can be used. They will increase nitric oxide production, which will lead to vasodilation because they increases cyclic GMP. Refractory pulmonary hypertension can be treated with lung transplant or heart-lung transplant in case of Eisenmenger's physiology. Balloon atrial septostomy results in right to left ventricular shunt, which will increase cardiac output and net tissue oxygen delivery. And it decompresses right ventricle and improves hemodynamic performance. So this is the end of the lecture. I hope you learned something from it. If you do, please like my video and share it with your friends, and subscribe to my YouTube channel so that I get motivation to make further videos. Thank you so much.